Good evening, everyone. Thank you for joining us. I'm Dr. Forrest from the Biology Department at South Texas College. And today we have a guest that is going to be talking about suicide prevention, individual and community strategies. So Dr. Lorena Reina is a double board certified adult, child, and adolescent psychiatrist. She's native to the Rio Grande Valley. She received her Bachelor's of Science degree from the University of Texas Pan Am. And she obtained her MD from Baylor College of Medicine, followed by her general psychiatry residency at UT Southwestern Medical Center. Dr. Reina then completed a child and adolescent psychiatry fellowship at the Warren Alpert Medical School of Brown University. Currently, she practices at Tropical Texas Behavioral Health and is assistant clinical professor of psychiatry at the UT Rio Grande Valley School of Medicine. Thank you so much for joining us, Dr. Reina. The floor is yours.
Thank you so much, Dr. Force. All right, so we will get started. So some disclosures, I have no financial disclosures to report today. And also, the views that I share during this presentation are my own and are not associated with Tropical Texas or the UTRGV School of Medicine. I do want to give, a couple of warnings. So talking about suicide can raise a lot of feelings with everybody. And so content from this presentation can be very sensitive. So I want to make sure everybody keeps that in mind. So listen to your body. If you feel some of the things that we're talking about seem a little heavy or a little bit much, please feel free to step away if necessary. So always listen to what your body is telling you. But I wanted to talk first about some stats about suicide and kind of give you all some just general information about it. So currently, suicide is the 11th leading cause of death in the US. We have some data from 2021. We don't have the numbers from 2022 quite yet, but in 2021, about 48,000 Americans died by suicide, about 132 suicides per day. And if we look at it more in a population standpoint, about 14.4 individuals die by suicide for every 100,000 individuals. Now, some of these numbers, though, might be an underestimation of what we're actually seeing because suicide sometimes is not reported as a suicide. So things like, accidental poisonings or accidental falls, could be suicides, but they were not reported as such. So this is likely an underestimation of the total numbers that we see in the US. In general, men die by suicide 3.9 times more than women, and over 50% of suicide deaths are due to firearms. And if we take into account things like age, gender, ethnicities, the highest rate of suicide we do see in middle-aged white men, although some things have been changing in the last couple of years. If we break this down a little bit further, so the highest suicide rates that we do see in the country are among the white population. So that's about a 17.4 per 100,000. So a little bit higher than the average of 14 that we have. But the highest is for the American Indian and Alaska Native population, 28.1. So essentially almost double the amount that we see on average in the US. If we break it down a little bit differently by age group, 25 to 34 years of age, it's an age group that we do see higher rates of suicide, so our young adult population, as well as our older folks, so 85 years or older. I am a child psychiatrist, so I did want to focus a little bit more on children as well as young adults, college-age students. And for ages 10 to 24, it's the leading cause of death compared to a single medical illness. What this means is that if you take, for example, deaths by cancer or things like neurological conditions, right, or cardiovascular conditions, so like heart attacks, things like that, suicide will be at the top of the list. If you add in things like accidental deaths or things like car accidents, things of that sort, then suicide drops to about the second or third overall cause of death. It really depends on the data that we are looking at. But it's a problem, right? I mean, it's pretty high up there in causes of death of our young population here in the US. And pretty, alarmingly, suicide rates have increased 52% from 2000 to 2021. And for this age group that I'm mentioning or talking about, it does account for 15% of all suicides. So these are pretty alarming numbers. And I wanted to focus a little bit more specifically on Hispanics and mental health. So for Hispanics ages 15 to 34, suicide is the second leading cause of death. And in our population, we see about 7.9 per 100,000 individuals that die by suicide, so lower than the US average of 14. But I would say in the last maybe 10 years or so, 15 years or so, there's been a lot more research into the Hispanic population, Latino population here in the US, because there are differences that we do see between ethnicities. And what was found was that Hispanic high school girls have a 30% higher rate of suicide attempts compared to non-Hispanic Caucasian girls. And about 1 in 6, so 17% or so, of Latino high school students had serious thoughts of suicide. And with all of this, even though we are seeing high numbers, especially in our young Latino population, overall Hispanics are 50% less likely to receive mental health treatment compared to non-Hispanic whites. So this is, we need help in our population. But unfortunately, a lot of them cannot access mental health care for many, many, many reasons. And I wanted to show you all this figure right here, which shows essentially just a figure of the suicide rates among Hispanics if we break it down by age. So you are able to see here that it is below the overall US average, which is the little green line. So we're a little bit below, but you see that peak, right? It goes a little bit higher in the ages of 24 to 34 that I was talking about, and 15 to 24. So these are two of the highest age groups in which we do see a little bit higher suicide rates compared to other ages. But there are new trends that are occurring, in the United States. So even though the rates were increasing for since the year 2000, basically, we did see a 2-year decrease in suicide in 2019 and 2020. Although I do feel a lot of this is part to COVID and being in quarantine. So we did see a drop in suicide attempts during that time. But since then, the rates have started to come up once again. So mainly in the non-Hispanic American Indian or Alaska Native persons. So the ones that I said have the highest here in the US of 28.1 per 100,000 individuals. Also in Black or African American individuals and in Hispanic individuals specifically. But for non-Hispanic white individuals, there's actually was a rate decline of 3.9% in 2021. So there is a little bit of a difference in this. Next, I wanted to talk about some risk factors for suicide. Now, there are several of them out there, but these have the most evidence of raising the rate of suicide. So, of course, psychiatric disorders are one of the biggest ones. So those individuals that die by suicide, about 90% of them have a psychiatric disorder. The most common will be depression, but also we see suicides occur in bipolar disorder, in schizophrenia. In substance use disorders, it's a big one, especially in opioid use disorder, which we are seeing with a lot more frequency in the last couple of years. We are in an opioid epidemic. And part of that is because with substance use disorders, it does increase your risk of having things like depression or anxiety disorders, when those in itself also increase the risk of suicide. And then if someone is using substances, they might become intoxicated. And during an intoxication, people tend to be very impulsive, right? Or not really think very clearly. And that might be a time where they might attempt suicide. We also see it in neuropsychiatric disorders, so things like dementia or other neurological conditions that can affect behavior. Other history that we're looking at whenever somebody comes in with thoughts of suicide is, have they had a previous suicide attempt? If the person has a suicide attempt in the past, that does increase your risk of having a future event. Childhood sexual abuse is another common risk factor. as well, kind of linked to that, adverse childhood experiences. What I mean by that is, early on in development, when kids are very young and they're growing up, their brain is very sensitive to toxic stress. So if they have endured neglect, physical abuse, sexual abuse, witnessing things like domestic violence, violence in their home, parental separation, things like homelessness, not having enough food to eat, or they have a family member that's in prison or in jail. All of these things are very stressful to children. We actually do see changes in the brain that happen from this toxic stress, and those changes in the brain can lead to behavior problems, and they can lead to psychiatric disorders. And a family history of suicidal behavior is also very important to ask about. So especially if a person comes in and, they tell me that they lost a parent, to suicide when they were, 4 years old, for example, that patient is going to have a higher risk of suicide compared to a patient who had their father or mother die when maybe the patient, was 18 or 19 years old. So again, really a lot of big stressors in the early childhood period do make the most impact later on in the patient's life. There is a genetic link to suicide. So typically when I have a patient and I'm asking about suicide history in the family, I do ask, do you have a caregiver, or do you have any family members that have died by suicide or have attempted suicide, because it is genetic in some ways. Drug and alcohol misuse, which I already talked about that a little bit, that it does increase the risk of suicide, especially because of the impulsiveness that's associated with intoxication. Access to lethal means, this is another big one. So I mentioned that over 50% of deaths here in the US from suicide are related to the use of a firearm. So things like having guns at home, I do ask that when I'm talking to families, or even things like having a lot of medications at home, just kind of laying around, because people can overdose using those medications. Chronic medical conditions. So there is an association between physical health and mental health. They are very closely related. So if someone's physical health is not very good, this can be like chronic pain, for example, living with cancer, in which the person's quality of life is very poor. That does increase risk for suicide. And then even just physical disorders by themselves, like cardiovascular problems, so heart problems, neurological problems, kind of terminal conditions, also, do affect the brain in different ways, because it does create a lot of stress on the brain, and that can increase the risk of having depression, for example. Stressful life events. So we always ask when someone's coming in for an appointment, has something really stressful happened to you lately that you think might have set things off, right? That might have led to you feeling very depressed or suicidal. This can be like loss of a job, or a big move in which maybe the person now feels very isolated from everybody, or a divorce that might have happened in the family. So really any kind of big stressful event that the patient has encountered can be a risk factor as well. Now I wanted to change gears a little bit and talk more about psychological factors. So things that the person themselves is experiencing. So I put impulsivity as the very top of the list, because suicide attempts tend to be impulsive in a lot of the cases. If the patient feels very hopeless, they might feel that things are never going to get better for them. They are never going to get better. Their mental health will never get better. So sometimes they don't want to try. They might lose motivation for just, to live, essentially. Pessimism, so being very negative about a lot of different things. It might be more sensitive to negative social signals. So, maybe they received some type of critique that maybe it wasn't actually that bad. It was maybe more like constructive criticism. But that person might really take that in and turn it around and really think like, wow, like, I'm really stupid. Like, that was really bad. How could I have done that? I'm really not a good person, or I'm no good. I won't amount to everything, even though it might have been a very small comment. The opposite of that is that they might have a diminished recognition of positive social signals. So if they are praised about something, or they won an award, or they have excellent grades and they're being given, they're on the dean's list or things like that, they might not associate that with any positive feelings. Rather, they might just push it aside, or maybe they might not even believe that they deserve to be told positive things. Not engaging in treatment, this is one of the biggest ones that at least I see, because, and sometimes this is related to the person being so depressed that they really don't want to do much about that. They say, I don't want to take medications, I don't want to see a therapist, I just don't want to participate, I just want to be at home, I don't really care. This makes it really, really challenging, because when a person gets to that point, we're not able to provide a lot of help, at least in the outpatient setting, looking in a clinic, for example. So it does become very challenging to help somebody who at that moment might not want to be helped. It's not a psychological factor, but I wanted to include it anyways, because it is a red flag. If someone might look very depressed, they might be very hopeless, and then they start giving away their personal belongings, to me, that raises a red flag that there might be a suicide attempt in the near future. And now we have a figure here that I really like, because it actually shows us the risk factors that I was just talking about, but it breaks it down into how big of an impact they have depending on the person's age. So if you look at the orange ones, those are the individual risk factors, which are all of these right here. And then in the green, you have the environmental risk factors. And then you have all the way from predisposition, so like in utero, and all the way to an older adult. Now, the more shaded areas represent that risk factor has a higher impact on a possible suicide attempt. So family history, you see, it's kind of pretty deeply shaded almost all the way through, because like I mentioned earlier, suicide is, there is a genetic component to that. So there's a family history. It does increase the risk of suicide quite a bit. We also have here depression, which, usually for more depression or severe depression, we start to see in adolescence. So you start to see that it starts around there, although I do see depression in children as young as 5 or 6 years old sometimes. If you go to the environmental risk factors, so just things around the person. So one of the ones that's also like very shaded is the lack of social support. If the person is very isolated, sometimes they have tried to reach out to others and no one's engaging with them. Or sometimes, which I also see a lot, is that some people push others away because they might be depressed, or they're just the things that they do, behaviors. They might be very angry or lash out because they are depressed, and people start to leave their circle. And then the other one that's very deeply shaded is access to lethal means. So again, things like guns, a lot of medications. If there's an access to a way to, die by suicide and it's readily available, then the risk of suicide will increase as well. And I want to talk a little bit about major depressive disorder, which is a major risk factor for suicide. Like I said, there's a lot of psychiatric disorders that do increase the risk, but depression is probably the biggest one. So I wanted to review some of the signs and symptoms that we do see in depression. So typically for depression, you see depressed mood, although you can also see irritable mood. So the person might be very angry a lot. They tend to have a loss of interest, so they don't really care about things anymore. Maybe they were an artist and they were painting and drawing. They have stopped doing that. They might stop, hanging out with their friends or going out to restaurants, or maybe they really like going to the movies. Well, they stop doing that as well. They might just be in the room doing nothing, most of the day. Changes in appetite. So either the person maybe might stop eating or not eat as much, or the opposite. You can see that some people start to eat a lot. So asking about weight changes is important, because we might see a weight loss or a weight gain when there is depression. Low energy or fatigue. Typically, people that are depressed do say that they just feel very tired. They feel exhausted all day long. It doesn't matter how much they sleep, they feel very tired. Changes in sleep. So someone who is depressed may not get a lot of sleep. Their sleep patterns might change. They might just get a couple hours at night, or the opposite, they might start sleeping a lot. The next one is feeling worthless or guilty. The person can also have some difficulty concentrating. So it's not uncommon that someone comes to the office and they'll say, I think I have ADHD. And when I ask a little bit more closely, it ends up that it's not ADHD, but the person is depressed, because if your brain is depressed, you really can't think very well. And I would see this a little bit more in the older population, but sometimes a very severe depression can look like they have Alzheimer's. So it does affect concentration quite a bit. Recurrent thoughts of death, so thoughts about suicide, is another symptom. And the other thing to keep in mind is that for major depressive disorder, the person's functioning is affected. So I do ask, how has this affected you? Have you seen a change in your life because of all the things that you're experiencing? A lot of the times, if they have a depressive disorder, it's a yes. The other thing for these symptoms, we need at least 5 to make the diagnosis of MDD. But at least, one of the symptoms have to be depressed mood or loss of interest, and the symptoms have to be present for at least 2 weeks. Although typically I see the symptoms, that are there for weeks, months, even years. Now, this, talk is about suicide prevention strategy. So we're going to start getting into that a little bit. So I have a figure here that I like because it basically shows us the timeline between when someone might start to have a suicidal thought or suicidal ideation, and then what are the factors that might go into eventually attempting suicide. And kind of along the way here, there are various prevention strategies that we can do to try and decrease the chance that the person eventually will attempt suicide. And we're going to talk about a couple of them in the next couple of slides. So one of the biggest ways that you can lower suicide rates in the country is actually awareness and education strategies. So there's been a lot of research into what kind of education is needed, who are we educating, who are we raising awareness, and is that effective or not? One of the research studies, or several actually, that looked at educating primary care doctors or general practitioners. Actually, we did see a very big decrease in suicide rates. The reason for this is that doctors in primary care, your PCP or maybe other non-psychiatric settings, actually see 45% of those that die by suicide 30 days before their suicide. And 77% of these individuals are seen within 12 months. So us in psychiatry, we're actually not seeing, these patients as much as their primary care doctor. And these patients might go for something totally unrelated. They might be there because they have a sore throat, or they have a urine infection, or they have back pain or something like that. But they might not bring up the fact that they're depressed, or that they're struggling, or that they're having suicidal thoughts, because there is sometimes a stigma, for that, or they might feel ashamed to talk about it. Or also they might say, well, my doctor, maybe they don't have time, and, they just need to see the next patient. So I'm just not going to say anything. I'm just going to keep it to myself. But the thing is that if we train these doctors, nurses to help better screen and treat depression with the help of psychiatrists, maybe, having a psychiatrist available to consult, we do see lowered suicide rates, lowered rates of non-fatal suicide attempts, lower suicidal ideation in patients. So there is a change that we do see, but you can't just go, to a clinic, for example, or a healthcare system and say, okay, everybody, we're going to do a 4-hour training on suicide awareness today, and then not repeat the training anymore. In order for things to be successful and actually do or implement a change and see a good change within the healthcare system or the clinic, the trainings have to be pretty regular, so not just a one-time thing. The other prevention strategy that shows a lot of evidence that it is helpful helpful is actually educating our young population. So 50% of lifetime mental illness is present by age 14 and 75 by age 24. So these are our middle schoolers, high school students, college students that are beginning to have the first signs and symptoms of a psychiatric disorder. And they might not know what is going on, or they might be confused over what they're feeling. So actually educating high school students, this was a study that they did on mental health, reduce suicidal behavior and suicidal thoughts. And, we think that you can probably extrapolate this into like middle school, age students, as well as maybe college age students. There is a popular program out there that does awareness and education for our young population. It's called YAM, or Youth Aware of Mental Health. And I put the components on here just so you can see what things are talked about in these programs and how these topics can help students understand their mental health better. So they do talk about having an awareness of mental health in general. They talk about self-help. They go over, if what to do when you're feeling very stressed, or maybe there's a crisis, how do we handle that? They go over depression, kind of the signs and symptoms of that, as well as suicidal thoughts and what to do when those are present. And as well, a lot of the time, especially in the younger population, adolescents, they might not feel comfortable reaching out to a caregiver or a parent telling them that they feel bad or they feel depressed, but they will reach out to a friend and tell them that they're not feeling very well. So during this program, they actually say, hey, if a friend comes up to you and they say they're suicidal, how do you help them out? Because if you would ask the average student, if your friend told you they're suicidal, what do you do? You might get, oh, I'm not sure, or they might start, worrying or panicking, right? So this educational tool will at least give them some guidance of like what to do if someone approaches you. And of course, they also get advice of like who to contact if you're not feeling well. Who do you reach out to if you don't feel safe? So this works very, very well. So actually talking about suicide in this case, the high school population, educating them on them does, we do see benefits from this. There's been, some studies that focus on education of teachers. Like, well, what if you educate teachers on having them be more on the lookout for students that might be depressed? Those haven't panned out as well in terms of having a big effect on lowering suicide rates. But the studies on these are very limited, so I feel they haven't done enough of them to really know. But some of the programs include not just educating the teenagers, but also educating teachers and doing trainings with them as well. Some other tools that we can use include screening tools for suicide risk. That's things like right here we have like the 4 Ps, which basically ask the patient, have you ever attempted suicide in the past? Do you have a suicide plan? What's your, are you likely to go through with the plan? And are there, preventative factors? These might be things that keep you from harming yourself. This might be like, well, maybe my family keeps me from hurting myself, or my dog, my pet. Graduating college, having a future, all of those things are preventative factors. And then there's also the Columbia scale that we see right here. Now, these two they tend to be used in clinics, in emergency room settings, for example. There are some emergency rooms out there that have started to implement screening everybody for suicide that walks into the ER. There's been some pros and cons about doing that. A lot of the times we do get some, I guess you can call it false positives. Like, they might say, oh, they might say yes to a suicidal thought, but then when you ask them further, it actually was not a suicidal thought. It was something different, but they might have interpreted the question wrong. So there's, some variability with doing this in our community in the emergency rooms, but there are hospital systems that are starting to do this. And then if a patient, does say that, yes, I am, suicidal, or I'm feeling depressed, then, the emergency room will have some policies in place on what to do next. How do we get the patient help? In a just regular doctor's office, we are seeing the use of something called the PHQ-9, or the Patient Health Questionnaire 9, which is a screening tool for depression. So it's not specifically asking just about suicide. It actually asks about all the signs and symptoms of depression that I talked about. And then at the end of that, it does ask, have you been having suicidal thoughts? I do like the PHQ-9. I think it is a very good screening tool that is very easy to use. Essentially, you give the handout to the patient and they fill it out. And then afterwards, you can review the answers and then just clarify and make sure that they answered correctly, because sometimes they do misinterpret some questions. So we do, at least in the in PCP offices or general practitioners' offices, they're using this a lot more, and maybe that's a better way to help start the treatment of depression for somebody. But also, to keep in mind that these are screening tools. Just because someone shows positive, or a lot of symptoms on it, does not necessarily mean that they might attempt suicide or that they have depression, because some of the signs and symptoms of depression overlap with other psychiatric disorders or other things. So we also have in mind. Now, awareness and education is very, very important, but it is expensive. It can be difficult to do, especially if we don't have enough resources in the community. One problem can be, for example, in the ER, like, okay, yes, we are screening everybody for suicide, but do we have enough? What do we do from there? Do we have enough psychiatrists to see the patient after that? Do we have enough hospital beds to hospitalize patients? So there are some limitations. But in Denmark, back in the 80s, they had one of the highest suicide rates in the country, 38 individuals per 100,000. But with time, they were able to bring that down to 11.1 per 100,000. So how did they achieve this? Well, they did a couple of things. They implemented means restriction programs. So really taking a look of like, what are the most common ways that people die by suicide? That could be, for example, guns or overdoses, and then trying to set some restrictions on that to limit the availability of certain lethal ways of dying. They increased psychiatric services by 66%. I can't even imagine, this being done in the US or having such a big increase in psychiatric services, but they were able to do it in Denmark. They opened suicide prevention clinics, so they were, patients had access to therapists and just regular follow-up to make sure that they were doing okay. They started having emergency outreach teams in their communities that can go out and make sure that patients are safe or screen them for a psychiatric admission. And then they also implemented a post-discharge program. So, when a patient goes to the psychiatric hospital and they are discharged, there are things that need to be done in order for the patient to have a good success in their treatment. So they might need to go to the pharmacy and fill their medications. They might need to be set up with an outpatient psychiatrist to see them. But that can be difficult. Patients, might not be able to drive to the pharmacy to get their medications, or because of transportation problems, they lost their appointment to their psychiatrist. So these post-discharge programs reach out to the patient after they were discharged and ask, like, hey, how are you doing? Are you doing okay? How's your depression? Have you had suicidal thoughts? But then they also ask, have you been able to get your medicine? Are you taking them? Did you follow up with your therapist or your psychiatrist? So really trying to make sure that patients don't fall through the cracks. So doing all of this had a big impact in Denmark. And here in the US, we do see bits and pieces of these methods here in the country. But, as you all likely probably are aware, is that we don't have enough mental health resources in the US, in the Valley in particular. We don't have a lot of specialized help. We don't have enough therapists. We don't have enough psychiatrists. We don't have enough child psychiatrists. So all of this does, limit the the availability of some patients receiving the help that they need. All right. Another prevention strategy is treatment, and there's different types of treatment that I'm going to be talking about today. So we'll be talking about medications for psychiatric disorders. We'll be talking about psychotherapy or talk therapy for depression and other psychiatric disorders, as well as lifestyle interventions. So what can the individual do to improve their mental health and hopefully decrease the risk of, a suicide attempt down the line? We won't talk much about brain stimulation or ECT, electroconvulsive therapy, but I just still wanted to bring it up because it is an important treatment in psychiatry, especially electroconvulsive therapy, which I think has a bad rap because of a lot of things in the media or in the movies. But ECT in particular has one of the biggest success rates in terms of treating a severe depression. So it is available in some places here in the Valley. I don't believe we have this available. And then the last one, we won't talk about it much, but school-based interventions. This is something that is being seen a little bit more in the US in the last couple of years. Also, we do have this in Texas. So essentially that would mean having access to a therapist during school hours and maybe even having access to a psychiatrist during school. All right, so in terms of treatment, a lot of people say, okay, like I'm interested in getting help. I'm not feeling well, but what do I do? Where do I start? It might feel very overwhelming to even take the first step in asking for help. But really the important thing is that we need to ask. This could be asking a school counselor, for example, that might be able to direct you to the proper office, for additional help. It might mean asking a parent. It might be asking a friend who maybe is receiving mental health care. They might be able to guide you. You can also make a medical appointment with your doctor as well and talk about it, because they, will be able to refer you to the appropriate individuals, that can provide you with a little bit more help if needed. Or sometimes your PCP or just your general doctor can start treatment for depression, without having to go to a psychiatrist. And, if you have a family or friend member that seems to be struggling, encourage them to ask for help. You might be, one to help facilitate. You might look up numbers for them and being, hey, like, you need some help, like, let me try and help you out. Because some depressed patients, again, lack the motivation, and they might need someone to push them and to show like, hey, someone cares about me. They want me to get better. They're helping me out. Let me go ahead and at least go to that first appointment, which can really make a big difference. So always ask. I also wanted to talk about the differences between psychology and psychiatry when it comes to treatment, because feel these two terms are used very interchangeably, and it can be a little confusing to know what is what. So I wanted to talk about that. So a psychologist, they have a doctorate degree, PhD or PsyD. They did college, grad school, internship, and some of them do even more specialized training, but they are focused in providing psychotherapy or different types of therapy, as well as doing things like psychological testing, but they do not prescribe medications. Now, there are other individuals that can also provide psychotherapy. These are licensed clinical social workers, licensed professional counselors. There's also marriage and family therapists that are able to do this as well. But definitely, if you're interested in seeing a therapist, always ask what their qualifications are. That's very important. Sometimes there's some ads out there about like life coaches, or life trainers. There's a lot of different terms out there, but these individuals may not have like a certification to do therapy. So you just need to be very cautious of like what kind of services you're getting from people. I'm not saying anything against a life coach. It can be helpful as well, but we cannot really, it becomes a problem when you start blurring the lines when you're starting to do more psychotherapy or therapy, because it is difficult to do well, and you need to have good expertise in doing it. And then for psychiatrists, which is someone like myself, we are MDs or DOs, and we do college, medical school. We do a psychiatry residency, which is 4 years after medical school. And then some of us choose to do a little bit more specialized training, which is a fellowship. So in my case, after I finished my general psychiatry residency, I did child and adolescent psychiatry after that. But there are other psychiatrists that do more training in things like addiction psychiatry, or even in geriatrics, which is just really focusing on the older population and taking care of their psychiatric needs. We are trained in the medical model of treatment. We are the ones that prescribe medications for a psychiatric disorder. That's what we are trained to do. And we can also be trained in psychotherapy, not to the degree likely of a psychologist. And the psychotherapy training with psychiatrists is variable. Some of us have more, some of us have less. But we are at least somewhat, we do have some training in psychotherapy. For myself, I do like to practice, and a lot of psychiatrists do this as well, something that we call the biopsychosocial model. So it's a way of looking at the person as a whole and trying to look at all the different components of a person and try to figure out, how to best to provide help. So basically biological. So we look at a patient's family history. Is there a family history of suicide? Is there a family history of suicide attempts, of severe depression? What about the patient themselves? Do they have a physical health disorder? Do they have cancer? Do they have a autoimmune disorder? Do they have high blood pressure? What medications are they taking that might be, because some medications do affect mood. We looked at their psychological factors, which again might be things like pessimism, hopelessness, maybe some type of personality traits like narcissism or being very perfectionistic or very rigid. Sometimes that is not very good in terms of treatment. And we also look at social factors. So what is happening around the person that might be affecting them? Did they recently, get kicked out of their home? Did they lose a job? How's their family life? Is it a supportive family, or are they isolated? Is it a toxic environment in the home with people fighting? Because all of these things taken together can help formulate, what we feel might be going on with the person, and we can try to help them out as much as we can, the more we understand them. But of course, we need the patient to be forthcoming and let us know, right? Because otherwise, we can't help as much as we would want to. The other thing I wanted to bring up is that some psychiatry clinics or behavioral health clinics might also have nurse practitioners or physician assistants that can provide some behavioral health care and prescribe psychiatric medications. And typically they work under the supervision of a psychiatrist. The other treatment strategy that has a lot of evidence towards preventing suicide, preventing suicide attempts, and as well as really helping, depression, is a specific type of therapy called cognitive behavior therapy. Now, like I mentioned earlier, there are so many types of therapies out there. There's therapy for a lot of different things, and there's different ways of doing therapy. So this one in particular, I wanted to bring up because it does have the most evidence, really, if you compare it to maybe other forms of therapies or therapies. So cognitive behavior therapy is evidence-based treatment for depression, but it can also be really helpful in other psychiatric disorders, things like anxiety disorders. This one, it can be super, super helpful. Generally, there are 1-hour sessions, an average of 12 weeks. And this is can be provided by a psychiatrist, a psychologist, LPCs, clinical social workers. But we need to ask for it, or you can ask, are you trained in CBT? Are you familiar with it? Is that something that you can do to help me out? So it's always, you can always ask these questions of whoever you're seeing, because it is your mental health, it is your healthcare. So, you should be able to really ask the questions about the type of treatment that you're receiving. So in CBT, the gist of it is that you're changing perceptions that the person might have, because thoughts, the things that we think about, can affect our emotions and can affect our behaviors, and everything is connected to each other. So I'll give a little example to maybe make this a little bit more clear. But let's say you receive an email from the dean saying, hi, can you please, see me in my office tomorrow at 4 o'clock? Well, if you get that email, and you usually have like a very automatic thought that's going to pop in your head that might be, oh my goodness, what did I do wrong? Did I fail the class? Am I getting kicked out of college? What is happening? So if you have that thought, which is very, very negative, you're going to start to panic. You're going to feel nervous. You might start to feel sad because your thought led for you to have these very strong feelings and very strong emotions. And if you have these very strong feelings, maybe for the rest of the day, your behavior might change. You might not be as engaged in your classes. You kind of can't really concentrate because you're so worried. Some people, when they're worried, get upset or very angry or snappy. That might happen as well. So you can see how this is all related. But in CBT, you really try to challenge people's automatic thoughts to try and make them, at least more positive or maybe at least neutral. So for example, if the person receives this email, they'll look at it and they might say, oh, maybe this is about the project that I did last year. Maybe they want me to present, or maybe I'm getting an award. If that thought is very different, right, compared to like, oh my goodness, what did I do wrong? So if you have a more positive thought, your emotions are going to be neutral or more positive, and then your behavior will be okay. It won't really change for the rest of the day. You can see how just changing a thought or changing our thinking patterns can really make a difference in lowering the feelings of sadness and lowering the feelings of anxiety. And it can also change the behaviors that we do for the rest of the day. Now, I also wanted to talk about some maybe individual strategies that one can do to just improve their mental health in general, because if you improve your mental health in general, then get, less likely that you might, fall into a clinical depression. Or if you are depressed or feeling very anxious, all these strategies can be very helpful in making the person feel better. So mindfulness is something that has been more at the forefront lately. And I feel a lot of more people are talking about it. So it is a form of meditation, but you focus on being in the moment, so you're really aware of what you're feeling, but you're also aware of your surroundings and really not having judgment on it. You kind of you're aware of it and that's it. You're not going various rabbit holes thinking about different things. And mindfulness can look like, doing certain breathing exercises, guided imagery. This means that you close your eyes and you think about somewhere that you really like. Usually it's some type of like peaceful setting. It might be, you're at the beach or you're in a forest, or you're in a nice garden with a lot of flowers, and you really focus on that image and all the details that you can. And after, a couple of minutes doing that, once you kind of open your eyes, you take a deep breath, you're going to feel that you're going to feel more calm. So that's a good strategy, especially when someone is going into like a panic attack or they're very anxious. Using things like guided imagery or breathing exercises can really bring things down in your brain so they're not as erratic. It might make you feel better. The other popular, form of mindfulness is a body scan. So basically this can be done like sitting or laying down, like on your bed. You close your eyes and you start focusing on like your big toe. And you just have all your energy on the big toe and how it feels. And you're like super focused on it. But then you slowly start to focus on other parts of the body going up. So you might focus on your toe, and then you might go down all your toes. And then you might focus on your ankle, and you kind of start working your way up the body all the way to the top of your head. And this is going to take a couple of minutes, but after you're done, open your eyes. And again, you might feel a sense of calmness after doing that. And there's a lot of other ways to practice mindfulness. YouTube is actually a really good resources for mindfulness exercises. So if you don't know where to start, there's a lot of guidance videos out there. So they actually guide you through these exercises, which might be nice to do, or at least try out. interventions, things that we can do ourselves just to improve our mental health. So eating well is one of the big ones. If we're not nourishing our bodies, then we are going to be more likely to not feel very good. Things like gardening can be very helpful. Journaling is a good way of kind of letting your feelings out and expressing yourself in a journal and just on writing down what you're thinking. Going out for walks, having pets can be really helpful as well. Things like listening to music, drawing, reading. So things that you like to do, make sure that, you focus on yourself as well, because I feel a lot of the times we are so busy or we're taking care of so many different things, or we're studying, we're working, we're taking care of family members, and then you don't really have time for yourself. And your brain feels that, your brain needs to be, needs rest, and it needs to heal, needs nourishment. If you're not providing that, you're going to feel very burnt out. Exercise is a very, very good antidepressant. I know that one is a little bit harder to do for some of us than others, but it does have very positive effects on mood, especially if you keep doing it. It doesn't even have to be like very strenuous exercise, but even just going out for like, a 20, 30-minute walk, I mean, that can be enough to have some positive effects on your mood. And the last one is sleep, of course. So if you're not sleeping enough, then your body is going to feel very, very tired. You're not allowing your body to rest, and you're going to be more cranky. It's less likely, if someone's not sleeping well, it's less likely for their depression to get better also, because you do need sleep. It's a huge, important part of just our daily living. The next treatment strategy for prevention of suicide are medications. And I won't go into like a lot of detail on this, but hopefully just enough to give you a general idea of medications and what we typically use to help treat depression in this case. So they do carry a lot of stigma. I feel there's a lot of things out there regarding psychiatric medications, even things online that might not be very true. And even like amongst doctors, there is a stigma against psychiatric medications. I feel that they're blamed for everything. So it's kind of like a joke in psychiatry, but if someone's feeling bad, and this is totally a joke, but they might be feeling bad and they go to see another doctor at the emergency room, and they might be like, oh, it's your psychiatric medication that's causing you this, please stop it. When it really was likely not the psychiatric medication. So there's a lot of stigma really across the board. But, medications, the goal is not to change a person or to have somebody become addicted or dependent on a medication. There are some medications that can be addictive, things like Ativan, Xanax, things like that. But a lot of us, at least for myself, we try to stay away as much as we can for those medications, because we don't want our patients to end up with another problem down the line of not having an addiction. But medications in general can be very helpful. Antidepressants in particular is what we use to help treat depression. But even though the name is an antidepressant, they're also helpful in treating anxiety, PTSD, OCD, and kind of other psychiatric disorders. So we use them for many different things. The most common antidepressants, and there are several classes of them, but the ones that we tend to prescribe first is a class called selective serotonin reuptake inhibitors, or SSRIs. And I listed a couple of these medications. The first three are the top ones that we prescribe. So fluoxetine is Prozac, sertraline is Zoloft, and escitalopram is Lexapro. So those three are my go-to, when first starting treatment for depression. These medications are actually, they're generally pretty safe. They have side effects. Any, medication that you take has the potential for side effects. For SSRIs in general, we might see headache, upset stomach, nausea, maybe some diarrhea. It doesn't tend to be like that bad though, especially if we start a low dose of the antidepressant and go up slowly. Sometimes people get side effects if the dose is too high, or it went up a little bit too fast. And they They do, unfortunately, take several weeks to work. So it's not something that you take and that is like a happy pill, and a couple of days later, you're like super happy, your depression is gone. That's not how it works. So these medications do take several weeks. There's some changes that happen in your brain when you take them that I'll talk about in a little bit. But after some time, you might notice that, okay, things are actually a little bit better. The changes are very subtle in the beginning. Usually the patient doesn't improve, or they say, I don't feel anything. But the parent might say, I see them smiling more. They're coming out of the room. They picked up drawing again. All these things are very positive. And really for these medications, it might take, 3-4 months for us to see, a big benefit from them. And sometimes we do have to, adjust the dose little by little. So it's important to, not give up so quickly, and give it time to work. And we do see a little bit faster improvement in depression or in depressive symptoms when you do a medication with therapy together. Now, if someone's coming in with more of a mild depression, I might say, I think, maybe you should just do psychotherapy. We don't necessarily need a medication, but if someone does come with a more moderate or severe depression, then I will, typically recommend starting a medication. The other thing about these medicines, which applies to our adolescents or children or young adults, is that they do have an FDA black box warning. Basically, it says that there's a very small risk increase of suicidal thoughts and behaviors in those ages 24 and younger. People tell me, like, wait a minute, like, Dr. Rena, I thought you said that this will help my suicidal thoughts. And yes, generally they are helpful. What this warning says is that there's a small chance that it might do the opposite and make things worse. Now, this was based out of some studies, like I think it was like the late 90s, early 2000s. But newer studies that are coming out actually think that this might not be true, that the risk may have been overestimated. So I don't really see it in practice that people started medicine and they weren't suicidal and now they're suicidal. I don't think I've really seen it. But it's just still something that we tell patients because it's, the black box warnings still exist. Now, another common question I get is how do these medications work? How do they help me have better mood or improve my mood? I'm not going to get too much into this, but at least I'll give you a couple of details on it. So serotonin is a neurotransmitter in the brain, so it helps in brain signaling, and it is associated with things like behavior and mood. Now, here in this little picture that you see, little pink here and the pink here. These are neurons. So essentially they're nerve cells that, they're all over our brain. And they help with communicating, within our brain and to send signals to the rest of our body of like what to do. So this neuron in particular makes the molecule serotonin. So you can see the little serotonin here in the vesicle. And the serotonin gets shipped out. It comes in here in this little area and it binds to other neurons, and that's how it's able to send the signals down the line. Now, the production of serotonin is regulated. Our brain does regulate the production, and a way it does that is that there's a little receptor. You see a little receptor right here. This actually helps with the serotonin that's up here, bringing it back to the nerve cell that produces serotonin. So if you're bringing these little serotonin molecules back over here, you're going to have less serotonin here and less of a chance it's going to bind to the other nerve cells. So with these medications, what they do, a way on how to regulate serotonin and increase the levels in our body, because if we increase the levels, it's thought that maybe that will improve mood or anxiety. So the medications block this little receptor right here. So now these little serotonin molecules are not going up as much anymore. So you end up with more down here. That's the initial hypothesis on how the SSRIs work. And I say hypothesis because this is still actively studied. And the further we go on and we know more about these medications, it actually tells us that these medications are more complex than what I just talked about. So the serotonin, molecules and SSRIs, they might have a role in activating other molecules in our brain that are important for mood and behavior. These medications seem to be actually protective of neurons of our nerve cells, and it helps keep them healthy. So healthy cells, you can extrapolate that will mean, the person feeling better, right? They also make the connections a lot stronger between the neurons. So the brain signaling is a little bit better. And also, they seem to have an anti-inflammatory property. And one of the newer things in psychiatry and psychiatric research is how our immune system is involved in depression. And these medications might actually be doing a couple of things in our immune system to have an anti-inflammatory effect. And then that in itself may also help alleviate symptoms. So this area is actively being researched. So they're not very simple. There's actually a lot of good things about these medications, and we're learning a lot more about them as we go. The other way that I already talked about this a little bit, but I'll repeat it again, is another way of being able to prevent suicide, and that means restriction. So restricting access to the most available and lethal means. As a reminder, firearms are used in about 50% of US suicides. Now, in other countries, they've done things like gun access restriction, firearm buyback programs. Not very popular in the US, as you likely already know that. So here in the US, there's a big push towards just providing gun safety education. And if someone has a gun, educating maybe you should keep it in a safe or keep it locked somewhere. So it's just people don't have access to that. In other countries, a common way of attempting suicide was ingesting pesticides. So in other parts of the world, or even here in the US, they've done a lot more restrictions on pesticides and the availability of them. There's some people jump off a bridge, or they might jump in front of a train. So some places or communities have put barriers in front of bridges and railway stations to help prevent that. Also, another one that I tell my patients is to really have a really limit the access to medications, even over-the-counter stuff like Tylenol, Motrin, things of that sort. For patients that I see that have attempted suicide, a lot of times I tell the parents, please get a safe and put all your medicines in there. It doesn't matter what it is. It all goes in the safe, and only you have access, and you will give the medication to the patient. You're not going to give them the bottle and say, keep this in your room. No, you're going to give the medication one by one, day by day. In my adult, population, when I would see them, a way of limiting access is actually just writing a prescription for a 7-day supply of medication or a 2-week supply of medication, so they don't have big stashes. I'm not a fan of 90-day supply, which some insurances are requesting 90-day supply of all medications. I'm not a fan of that in psychiatry, because you can imagine someone who is suicidal and you give them 90-day supply of, maybe they might take 2 or 3 medications, and now you have given them so many pills for them to overdose with. So we got to be very careful with medication overdoses. The next thing, we're almost done, is making a safety plan. This is something that I encourage everybody to do, especially if they are struggling with depression and suicidal thoughts. Step 1 is knowing your warning signs. How do you know that you're not doing well? Is your sleep less, or are you sleeping more? Are you isolating? Are you more irritated? Have you lost interest in doing your stuff? What do you notice when you're not doing well? Okay, now make a list of coping strategies or coping skills. What can I do when I'm not feeling very good? Maybe I can listen to my favorite album. Maybe I can play my guitar. I can go for a walk. So you start listing things that you're able to do. Step 3 is, who can I call to distract me, or where can I go? So this might be, I'm going to call a friend and see how they're doing. I'm going to go to the park and take a walk. I'm going to go to the mall. I'm going to go to the movies. Step 4 is, all right, if I'm in a crisis, who do I ask for help? For kids, I usually tell them, you need an adult person in there that you can talk to, whether it's a parent or maybe it's a counselor or someone in school. And then step 5 is listing professionals or agencies that you can reach out to. So if you have a doctor or a psychiatrist, you can write down their information so you have that information readily available. And then the last one, which is super important, make the environment safe. Again, this might be putting guns away or even removing them from their home if it's possible, putting medications away. I do have some patients that cut themselves, so trying to limit, forms of cutting as well. And all of this goes into like a handout. So you actually write everything down and you keep it handy for yourself. And I would also say maybe a family member or a parent should have a copy of this too, because when someone is not doing very well, they might not be thinking very straight. So this kind of puts everything in like written down and you can reference it pretty quickly. Some people even keep it like on their phones, for example. And then if you're, a parent or a family member or a friend that might have someone's safety plan, you already know what to do instead of, panicking, right, when something like this is happening. Now, if someone is in a crisis, safety is the most important thing that really beats everything. So the person has to be safe. I did include a couple of numbers down here that are important for everybody to know. So I want to make sure I spend a little bit of time on this. I would take a photo, a screenshot, of this. And some of my patients, I say, just put it on your phone as a contact because you never know when you might need it and you don't want to be like Googling it. Just make sure that you have it, already have a contact on your phone that you know what you can press. There's also a text line that you can use as well. And of course, you could always call 911 or drive to an ER if there is a crisis. If an individual is at imminent risk for suicide, meaning that they are likely to attempt suicide, the recommendation typically is to go to the psychiatric hospital. Here in the Valley, we have 4 hospitals available, and typically like the local hospitals and the ERs can help transfer to these hospitals. Length of stay at these hospitals can vary. Average, I would say it's about a week, but some patients are there for less than a week. Some patients are there for more than a week. So it really depends on how, on many factors and how the person is doing. And there you typically have an access to a psychiatrist or a nurse practitioner or a PA that can help with medications. You typically also have access to individual therapy and group therapy activities. Things of that sort, and then they will help you, set up outpatient follow-up after that. So follow-up care. So one of the other very important prevention strategies for suicide is that we are actively, checking in with patients, especially after they leave the hospital. So like I mentioned earlier, calling them, hey, how are you? How are you doing? Were you able to get your medications? Did you have any problems going to your psychiatrist appointment? So keeping that communication open so people are not falling through the cracks. Now it is, even if you're not, in the hospital, but if you have an outpatient psychiatrist, making sure that you're keeping up with their appointments, that you're going to them. And we're going to help manage medications, but we can also direct people to other resources. The other thing to keep in mind, because I see this quite a bit, is that I have some patients that I see after a suicide attempt, I diagnose them with depression, we get started on a medication, and then 3 months later they say, oh, I stopped it because I'm feeling so much better now. That is not the best thing to do because our research tells us that a person needs a minimum, it depends on situations, but in general, a minimum of 9 months after they are doing well, of being on, that the medication needs to be on board. So let's say a patient is doing, really bad, their depression goes into remission, in January. Well, 9 whole months before we start to take off medication. So these medications, they do not need to be lifelong medications. We can always take medications away slowly and see if we don't need them anymore. In some patients, it is a lifelong medication, but it really just depends on the situation. Also, following up with a therapist is very important. Continuing to work on coping skills, on improving your physical health, because it is related to your mental health. So if someone has hypertension, they have diabetes, making sure that they are checking their blood pressure, they're taking their blood pressure medication, their sugars are controlled, because if those things are not controlled, then you're actually not going to see a whole lot of improvement in your mental health either. And the last thing, of course, lifestyle interventions. So we're near the end of our talk. So just in conclusion, here we have the little, figure that I showed a little bit earlier. So we have our suicidal thoughts that show up right here, and then our suicidal attempt, and all the things that go into play, and what educational strategies or treatment can be done in each step of the way. So just to review really quickly, so you might have a very, very stressful life event that happens. The person might have a psychiatric disorder. They might have acute intoxication, again, increases impulsiveness, right? And you might end up with suicidal thinking or suicidal thoughts. After that, we really take a look. Is the person hopeless? Are they pessimistic? Are they not engaging in treatment? Are they isolated? Do they have impaired decision making? Because all these things will increase the risk for suicide, as well as access to a lethal means. But if we're able to, somewhere along the way here, provide awareness and education, for example, to a primary care doctor, well, if someone has suicidal ideation, then they might be able to start treatment to help avoid a suicide attempt, right? So all of these things can really, if you add them up, can really make a big difference. That's the end of our talk. Does anybody have any questions?
Thank you so much for that talk. We have a lot of questions. A lot were answered throughout the presentation. So we selected a few, but we wanted to start with there was some curiosity, and since we have a lot of students from STC, there's a percentage of them that actually are still in high school because they're in a grade program, dual credit. And since you're from the Valley, we wanted to ask you, which high school did you graduate from?
I went to South Texas High School for Health Professions, or Med High, over in Mercedes, part of South Texas ISD.
Hey, awesome.
Great school, by the way, great school.
Okay, so we had a lot of questions that it's really an awesome talk. I actually, a couple of times, I had to go back to the questions because I was just in the presentation. But we had some questions that I have selected one, but that other participants actually had related questions. So, and I've kind of divided it by topic. One big thing which you mentioned is about that stigma. And there were a lot of questions, comments about why is mental health, especially including talking about suicide, such a taboo in society. And and like I said, there's a few questions, but I wanted to kind of start with this one. Is there specific differences in the way different generations view mental health? So is that a reason? And especially since you're a child and adolescent psychiatrist, what is your opinion on that?
Yeah, so we do see generational differences for sure in terms of how people view mental health. So, I think mental health is, it's being talked about a lot more now than it maybe was, 20, 30 years ago. I think, it carries the stigma, right? That if you seem depressed or you show symptoms of depression, or you're anxious, you might be viewed as weak, or like not good enough, or there's some type of like default, like, why can you just do this, right? Like, why are you not doing your schoolwork? Like, what's so hard about that? But there's this, there's a lot of misinformation out there. It's like, well, depression is a clinical disorder. It's a medical disorder. And I don't think the older generations understand that, I'm not saying everybody, but to some extent, it might not be viewed as a medical disorder. Psychiatrists, we are physicians. We went to medical school. The brain is an organ of our body. And just like someone can, get, high blood pressure or diabetes, are you going to say, oh, you have diabetes, you're weak? Why would you treat that? You're weak, just fix it yourself. Well, you can't tell that to your pancreatic cells, right? Like you need to get that treated. So I use that analogy, especially when I would see more adults, but I still use it with parents who might be like, está chiflado is the the usual one, or no quiere hacer nada, así es él. But it's like, no, like this is a real disorder. There are real changes in the brain. So really the best thing we can do as psychiatrists is to educate our community, especially our older population. Like, it's not really that, like there's more that goes into it. And I think it is getting better. It's talked about a lot more, but there's still this hesitancy to talk about it, in our community. I think in certain ethnicities, you also see it more. So Hispanic populations, Asian populations, you also don't really see family members talking about it or bringing it up. Sometimes it's just kind of pushed to the side or ignored because no one wants to bring up, oh my gosh, like, or, they'll say, I don't want to talk about that person over there. They're weird. Let's just ignore them, right? But that's so you're like shutting off somebody, and it has such detrimental effects to someone's mental health when they're ignored or they're not being paid attention to. So you actually end up hurting the person. So it's really all about education.
So that brings to something that a few were actually writing, and it was I chose this question, but a few were writing the same thing. Erica Estrada wrote, do you have any statistics on the negative effect of educating students about suicide awareness? And she added, because trying to inadvertently adding to the suicide tendencies.
Mhm. So that is a very common misconception. So talking about suicide in an educational way does not in any way increase the risk of having somebody attempt suicide. They've looked at this many different times. It is a really, really common misconception. That does not happen. And actually, as I mentioned a little bit earlier, it's helpful to have these conversations because you actually might end up helping somebody. So just because you mention, or you ask me, are you suicidal? That's not going to lead for that patient to then go and attempt suicide after that conversation.
Okay, and going with talking about getting help, right? And talking about it. There was a lot of questions on how to help someone that doesn't want or not want, doesn't acknowledge that they need help, that keeps pushing them. And it's like there was so many, but there were around that. What is the best way to actually help someone that is really pushing you, that they don't want help, that they don't need help, that they're fine, that how do you approach that? Because it could be frustrating.
Yeah, it definitely can be frustrating. Sometimes when people are reluctant to get help, it's coming from some type of fear. So even just asking them, like, is there something that worries you about asking for help? Are you scared about asking for help for some reason? So kind of trying to see if there's some type of fear or worry involved, because if there is, then that might make it a little bit easier to figure out what your next step might be. I feel a lot of the patients, especially, they don't want to go see a psychiatrist specifically. They will I've had some patients that tell me, well, I don't want to see the doctor that treats the crazy people, which I mean, it's true. That's what a lot of people think. And it's that misconception again, like, no, like that's not what we do. We also do not use the word crazy in psychiatry. That does not exist in my vocabulary. But okay, well, maybe let's talk to your PCP. That's usually a better way to get somebody treatment, is to not go take them directly to the psychiatrist, but maybe starting off with their primary care doctor, because it might be a more comfortable environment. Maybe it's a primary care doctor that they've known for like 5, 10, 15 years, and that conversation might be a little bit easier to do. But you probably will have to accompany that person to that appointment to maybe kind of push a little bit. But the and you can also sometimes do some, we call them motivational interviewing strategies, but you can also ask the person, okay, like, how you're doing, like, is it affecting you? Like, because I feel we're being affected here, because when someone has a mental health problem, it's not just that person, it's the whole family, that's being affected. So maybe, bring that in, maybe say, you're really affecting the kids, or you're, really affecting your mom by doing this or being like this, let's try and help you out. But honestly, like, at the end of the day, if you might try all these things. If the patient is not ready to get help and they're not ready to change, you have to give it time. But if it's until they're ready to do so and take that first step, you can continue giving education. You can continue, pushing here and there. But sometimes you just have to give them a little bit of space as well. Of course, if they are like, they're suicidal, you don't need permission to get, from them to get treatment. If they're suicidal, you're going to call 911, you're going to take them to the hospital, so they can do an evaluation there. And, I don't like to do this, but you are able to involuntary, take a patient to the hospital that really needs the help. So there are ways of doing that. And usually you have to call 911 if it's an emergency, and they will take it from there.
So we had some questions, and kind of remember we have students that are currently taking our biology courses, anatomy, and even genetics. And there were a few, but I selected this one from Gary Lee Nunez. Is there any way to use biology, like biomarkers, to help identify suicide? And I'm adding also even depression.
Mhm.
In and is there yes. So it's for and so that occur any changes that occur in the body to be able to detect it, like biomarkers or genetic markers.
Mhm. So that's a really good question. And that's where our research is heading towards too. So there are genes in our body that have, or parts of genes that have an association with suicide, with depression, but there's not one specific like gene, for example, or a specific marker that will tell you that. It's usually a combination of many different things, of the interplay between many different things in the body, many different molecules. But there is a lot of research, moving in towards that direction. Like, is there something that we can do to better help detect somebody that might be a high suicide risk, right? Because we can ask the questions, we can observe behaviors, but that is only part of the equation. Like, if we're able to have something a little bit more specific, like if this person has these changes genetically, they're 60% more likely to attempt suicide. Well, we're going to keep a closer eye on that patient if we know that information. We're not quite there yet, but it's in some things like that are being actively researched.
Okay. So I had a couple of more, but I think if we have from here, there was some questions on the medication and all of that. But one that I don't want to pass is about social media.
Mhm.
There were a lot of mentions about how social media can have an impact. So Adriana is asking, has social media had an effect on suicide rates? How do you think we can make this better?
Mhm. That's a more complicated question. In general, it does seem that the use of social media has contributed to a worsening of mental health in adolescents. So there are some newer studies out there that are coming out studying this information. And there seems to be an association, especially between heavy social media use and poor mental health outcomes. There's a lot of what I worry a lot in my adolescent population is bullying through social media, because it affects people so much. And I've had patients come in that say, I'm being bullied on social media. I had this video posted of myself, and now there's all these mean comments, and I'm getting death threats. And because of that, that person is suicidal. So clinically, I do see that, but it's very like specific to a person. I don't think like we can say like, the use of social media increases suicide rates quite yet because there's so many other factors that come into play. But there does seem to be a negative association with mental health, especially if social media is not used properly.
Yeah, we had one of the questions was actually mentioning cyberbullying.
Mhm.
Um, and and I wanted to add with it was one of the other questions related to social media was more specific on if a parent, is it proper to actually restrict social media, especially on an adolescent that's
Mhm.
showing signs of uh,
Mhm.
depression and suicide?
I will, well, adolescents are very clever about finding ways to still find access anyways. But if they're, I tell this to parents, I'm like, if you're paying for their phone, you should, and you should keep track of what's happening, and you should have all their passwords. You should have the passcode to get into their phone, look at their text messages. I know that's adolescents will probably not like that, but it is, it can turn into a safety problem. If there is something's going on the internet that the parents are not aware of. I've seen so many things. As a child psychiatrist, kids exchanging messages with older men. Here in the Valley, I've had patients who have been victims of trafficking, of human trafficking, through the use of social media. So it's not like we're trying to instill fear in people, but I tell parents, especially if you have an adolescent that you're really concerned about, um, have you need to have access to their phone.
Well, we ran out of time. I could probably share some of the questions so you can see from our audience. But thank you so much for agreeing to join us and sharing some of your knowledge. And thank you all those that joined. You have our YouTube page, subscribe, and you can keep up with all the other amazing speakers that we have. Thank you so much.
Thank you so much for